Welcome.
Okay.
3, 2, 1. We are live now, sir.
Okay, thank you.
Shweta, please share the slide.
Shall I share?
Shweta. With the permission, can I move? Can I introduce?
Just a minute, sir. नहीं सर नहीं. एक मिनट. ज्वाइन करने देंगे सर. 5 मिनट जरा देंगे. No, sir, you can start.
Sure.
Yeah, right.
Good evening, ladies and gentlemen. Welcome to the 4th anniversary of Secrets of Neurology. It's a knowledge feast for all neurologists. It's a journey full of exploration, enlightenment, and excellence in neurological science. Ladies and gentlemen, together with your support, we had 47 episodes. It involved 41 institutes. We did 47 unique cases. We had participants from 6+ countries, and there were more than 1,000+ participants and presenters. Courtesy our course director, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan. We can't be more grateful, extremely grateful to both of you, our program directors. And today, this can't be getting bigger and heavier. On the screen, ladies and gentlemen, you see Dr. Sudhir Shah, Dr. Lakshmi Narasimhan, and also PGI director and a leading neurologist of the country, Professor Dr. Vivek Lal sir. A warm welcome to you, sir, and to your lovely team, which we also see on the screen. So today's case is from PGI Chandigarh, and we know that these 3 different cases are going to be very, very exciting. Ladies and gentlemen, it's my honor and privilege to briefly introduce to you Professor Dr. Sudhir Shah sir. So first of all, many congratulations. On 5th of June, you made the entire nation proud. You got Bharat Gaurav in Paris by Paris Senate. The awards and accolades follows you, and I think this is just at the tip of the iceberg. You have been conferred the Padam Shri, you received PC Roy Award, and now the laurels that you brought to the country by French Senate Award. We all know sir very well. He's professor in HOD at SMT NHL MMC and SBPI MSR Ahmedabad, and sir is also director of neuroscience at Sterling Hospital, Ahmedabad. Dr. Sudhir Shah sir's interest is into stroke, neurodegenerative disease, and epilepsy. Ladies and gentlemen, our second program director, equally an academician par excellence. And thank you, both of you, for making it for the 4th year in a row. And we look forward to conclude the 5th year when we will have a grand celebration. Dr. Lakshmi Narasimhan, Director and Professor, Department of Neurology at prestigious Sri Ramakrishna Institute of Higher Education and Research. And before then this, sir was also heading Madras Medical College, recipient of Paltussi Advisor, A.B. Baker's Award, Best Paper Award from AN, and his contribution to national and international in the field of neurology has been par excellence. He has been mentor, coach, facilitator of so many young DM and DNBs in the field of neurology. May I request both our program directors to take this introduction of Professor Vivek Lal sir and his wonderful team and take it forward.
Yeah. Thank you, Dr. Manoj Kumar. Thank you for those kindest words. It reflects your love and affection towards me and Dr. Lakshmi. Ladies and gentlemen, I do not have proper words to describe my feelings today because we are entering today 4th anniversary, that is episode number 48 for Secrets of Neurology. Is Knowledge Feast for All Neurologists. You know, this is one of the most sought after lecture series, discussion series, and it is important to note again that the consistency, the quality, and the delivery of different topics is par excellence. And that is the reason why people always wait eagerly for the episode. As you know, we do it every 4th Friday of the month, and that is why today we are meeting. Thank you. I want to thank all the delegates for putting the trust in us and giving continuous encouragement. There are delegates from all over India and neighboring countries and distant countries also, and more than thousands of delegates have been participating many times. Thanks to my co-course director, Dr. Lakshmi Narsihan, whose tireless efforts has made this series very popular, and he has been pivotal in selecting the institutes. The important role is also played by Globusel team of INTAS for their logistic work and providing the networking. I want to thank Mr. Arun Chadda, Dr. Manoj Kumar, Dr. Shweta, and the whole entire team, Globusel team, for this. Now, coming to today's episode, now who could be more suitable and appropriate? Professor Dr. Vivek Lal and his team, that is Postgraduate Institute of Medical Education and Research, Chandigarh. The name of Professor Vivek Lal is not only known in India, but all over the world, from Japan to USA, from Finland to Austria, and all different parts of the world where he has been a sought after teacher, continuous medical educator, and rather an authority in several parts of particularly neurology. From PDI Chandigarh today is done by 3 resident doctors. One is Dr. Siddharth Chand, one is Dr. Riya Sharma, and the third one is Dr. Yatharth Dikshit. All 3 are DM residents, and each of them will present one case of neuro-ophthalmology and glandular infection, a spectrum. Dr. Astha Thakkar Kapila and Dr. Karthik Vinay Mahesh. As you know, Karthik is the assistant professor. He would give case localization, and Astha Thakkar Kapila would help us discuss the case. But the final comments will be made by Professor Vivek Lal. Vivek Lal, as you know, is a director. May I have the next slide, please, of PGIMR? Professor HOD. Next slide, please. Yeah. So, briefly introducing today's speakers, Dr. Siddharth Chand is 3rd-year neurology student, and he is MBBS from UCMS Delhi, and is MD Medicine from MAMC Delhi. Next slide, please. Next slide, please. Dr. Riya Sharma is a third-year DM neurology resident, and she did her MBBS from JLN Medical College, Ajmer, and then she pursued her MD medicine from SMS Medical College, Jaipur. Next slide, please. Yatharth Dixit is also third-year neurologist resident, and he did his MBBS from AFMC Pune, and then MD medicine from also AFMC Pune, and now he is pursuing DM neurology. Next slide, please. Karthik, as I mentioned, is an assistant professor, very upcoming promising neurologist, and he has his interest in neuroinfection, neuroimmunology, cognitive health, and neuro-ophthalmology. And in the path of Dr. Vivek Lal, his mentor, and he has been member of AN, member of Indian Academy of Neurology, and numerous international publications are to his credit. Next slide, please. Next, please. Dr. Astha Chakkar Kapila, Associate Professor from Department of Neurology, PGIMR Chandigarh. She is also very entertaining and very, I would say, proficient neurologist. And she has area of interest in neuro-ophthalmology, neuroimmunology, neuro-oncology. And at this young age, she has more than 120 publications in peer-reviewed national and international journals and 11 book chapters. She is an associate professor, principal investigator, and co-investigator in various ICMR, DST, sub, and various intramural projects. She is an associate editor to Urja, The Power of Her, Approach and Management Studies of Medical Ailments in Women. She invited faculty and delivered talks in more than 50 regional and national conferences. She has organized various CMEs and awarded 5 distinction medals during MBBS and other fellowship awards. Next slide, please. And what to say regarding our most beloved Professor Vivek Lal. I mean, whatever we say would be less for him. He's MD, DM, FR Civils, Edinburgh, FIAN, Director, Postgraduate Institute of Medical Education Research, PGIMR, Chandigarh, Professor and Head, and also former Dean Baba Farid University of Health Science, Punjab, Chairman Neuro-Ophthalmology Subsection, Indian Academy of Neurology, Associate Editor General of Neuro-Ophthalmology, that is Taylor and Francis. He has more than 200 index publications to his credit in several chapters in national and international journals, editor-in-chief in Clinical Approach to Neuro-Ophthalmic Disorders. If I go on counting his honors, awards, and accolades, I think our time would be over. But it's my humble duty to mention a few. He was invited as chair and faculty teaching course and scientific session neuro-ophthalmology on World Congress Neurology at Kyoto, Japan in 2017, 14th World Congress in Dubai, 15th World Congress in Rome, and 16th World Congress in Montreal, Canada. Very, very few neurologists have been honored with such a giant recognition year after year. So hats off to you, sir. The visiting guest faculty, University of Oxford, UK, March 2016. Teaching faculty, Medical Ophthalmology Society, UK, March 2016. Also visiting faculty in Neuro-Ophthalmology, University of Addis Ababa, Ethiopia. Is invited faculty in Neurological Conference in National Medical Academy of PG Education, Ukraine, and biannual meeting at Vietnamese Neurological Association 2019, and Cairo and Nice, etc. The Master Teachers Award at Shine 2016, Chennai, no doubt about it, no wonder about it. Pioneering work in the identification and discovery of ophthalmologic migraine in India for the first time. It is the single largest series in world literature on OM. And is the principal investigator and co-investigator in various extramural and intramural research projects, more than 150 lectures, at various national international conferences, organized various national international conferences, CMEs, public awareness campaigns. And it is my honor that he always accepts our invitation to give lectures and courses in neuro-ophthalmology at Ahmedabad. In my neuro update, we have finished 20 consecutive years of neuro update, year after year, and he has been invited more than 4-5 times. And his lecture, even if it is the last lecture or the first lecture, hall is always full, and the way he teaches lucidly, I mean, everybody really appreciates, and every time he gets standing ovation. So this gentleman is now heading one of the premium prime institution of India, and that is the director of PG Institute of Medical Education Research. So, dear friends, let us welcome Professor Vivek Lal and his team. And we are really grateful. I'm really honored, humbled, and very happy to have my friend and senior colleague and my colleague, Dr. Vivek Lal, today with us for celebrating 48th episode. Thank you, Professor Lal and the team. Thank you very much.
So thank you so much for this very kind introduction. Without much ado, we will go on to our case presentations. My team will now be presenting 3 different types of cavernous sinus syndromes. Please remember the cavernous sinus is a very strategic sinus and is often the site of mischief, both infective and non-infective. Today, we have decided to look at a certain non-infective, etiology called the IgG4 group of disorders. India is known to be the cradle of painful ophthalmoplegia. And as was just pointed out by Professor Sudhir Shah, we have got a plethora of cases of painful ophthalmoplegia. Now, the commonest cause of painful ophthalmoplegia in the Indian context obviously would be tuberculosis, followed by diabetes. But a significant amount of cases of painful ophthalmoplegia are non-infective, steroid sensitive in origin, and who on biopsy show us non-specific changes. My team will be discussing the approach to painful ophthalmoplegia, especially in relation to pathologies sequestered to the cavernous sinus. My team will also discuss how to nail down the exact cause, and finally, how to treat them and how to follow them up. So with that, I set the ball rolling. Siddharth is our DM student. He will be presenting the first case of a cavernous sinus syndrome. He will be followed by Yatharth and finally by Ria. So over to you, Siddharth.
Good evening, everyone. I'm Siddharth. I'm a third year, a senior resident in the Department of Neurology, PGI Chandigarh. I shall be presenting the first case of the evening, which will be a typical case of cavernous sinus syndrome. So we have a 32-year-old lady who had presented to us with complaints of headache for 2 years and drooping of eyelid and double vision for 2.5 months. So in the background, she was having a left-sided migrainous headache for the past 2 years, which was retroorbital, episodic, and mild in intensity, and used to occur once in every 1 to 2 months. And it used to get relieved on using oral analgesics. However, 3 months before presenting to our institute, the character of her headache had changed, and it had become localized to the left-sided frontotemporal region, and it had become continuous. And the intensity had also increased and it had become 8 to 9 on visual analog score. And she had no relief with oral analgesics. She also developed double vision, which was horizontal and binocular, and used to increase on seeing towards the left side, both for far and near vision. And 3 to 4 days later, she developed drooping of left upper eyelid with complete closure of left eyelid within 1 day. And these were the examination finding at the referring hospital. She had left eye ptosis and left-sided pupil was dilated. It was non-reactive, and she had impaired abduction of her left eye. Thankfully, we had we all know that we have to get imaging done along with the angiography. They got an MRI done at the outside hospital, and we can see that there was some T2 flare hyperintense mass along with contrast enhancement, which was pretty homogeneously along the left side of the cavernous sinus, which was also including progressing along the dura, and it was also extending up to the orbital apex. Here we can see that there was some heterogeneous necrosis in the pituitary mass, which was interpreted as pituitary macroadenoma with apoplexy. She was started on oral steroids. On starting steroids, her ptosis and headache responded. She stopped the medications on her own after 2 weeks. But after that, her headache and ptosis recurred, and then she came to our institute. When we examined her, we found that she was having left eye ptosis. Her left pupil was dilated and it was sluggishly reactive. She had left LR palsy and doubtful left inferior gaze palsy also. So the substrates which were included for headache, it was a left-sided first and second segment of the trigeminal nerve, probably due to the dural involvement. The ptosis and the dilated pupil were likely due to the third cranial nerve involvement, and the LR palsy was due to the sixth cranial nerve involvement. So here we have a diagrammatic representation of the cavernous sinus. So this is the third cranial nerve. Here we have the sixth cranial nerve, and this is the dura along which she had her involvement, as we can see in the MRI which she had got done in the outside institute. So by her clinical history and examination, we were able to localize the complaints to the cavernous sinus. Coming to the differential diagnosis that we considered, given the fact that she did not have any fever or she did not have any systemic complaints, the likelihood of infection was less, and she did not have any involvement of the paranasal sinus and the anterior cavernous area also. So we kept the differential of bacterial or fungal involvement less, and we focused our investigation to the non-inflammatory, non-infective inflammatory disorders, predominantly IgG4 related disorders and sarcoidosis. The reasons were that she was having an indolent course, she had dural involvement, and she had steroid responsiveness. And because of these reasons, the likelihood of vascular causes like IC aneurysm or neoplasms like pituitary macroadenoma was less likely. So the patient underwent routine blood investigations, which revealed mild anemia. She underwent CSF analysis also, which was normal. The opening pressure was normal, and the protein and sugar levels were also normal. The serum IgG4 level, which was done, which was also in the normal limits. Serum ACE and the vasculitic workup was also normal. Further, hormonal workup done was also negative. The reason for getting the hormonal workup was because outside it was interpreted that she was having a pituitary lesion. MRI was repeated at our institute, which again showed a homogeneously enhancing soft tissue thickening of the cavernous sinus, predominantly along the left cavernous sinus. And we can see that there was definite involvement of the pituitary area, and in between there is an hypointense lesion which can be appreciated in the T1 contrast MRI image, which is suggestive of a necrotic patch. And here we can see that this enhancing thickening is encasing the ICA also. Further, she underwent a PET-CD of the whole body, and it again showed an FDG away thickening in the left cavernous, along the left cavernous sinus. In the third picture, we can clearly appreciate that this thickening is actually extending along to the apex of the orbit and also extending along the tentorium of cerebelli. So then she underwent endoscopic transnasal sphenoidal surgery, and biopsy was done from the pituitary area. And the histopath actually showed that she had fibrinoid necrosis in the background, and she had dense infiltrate of the numerous plasma cells. And she also, there were few eosinophils admixed also. Special stains were used to look for IgG4, immunoperoxidase stains were used, and on high power field, the number of IgG4 plasma cells were more than 10, and the ratio of IgG4 plus plasma cells to the normal IgG cells were more than 40%. So hence, the histological diagnosis was IgG4 related hypophysitis. So the final diagnosis which was made was a left middle cavernous sinus syndrome according to the Ishikawa classification, lymphocytic hypophysitis, inflammatory granulomatous disease, and IgG4 related disease. So the learning points among this that whenever there is a differential involvement of either the inferior or the superior division of the oculomotor nerve, the localization is at the cavernous sinus or at the orbit. And here in our case, we had predominant involvement of the inferior division as she had normal superior rectus finding. Also, the most important learning point in this case is the serum IgG force may be normal, just like the levels in her case was only 398, which is in the normal limits. So these are the two learning points from this case. Further, in post-surgery, she developed panhypopituitarism, which was managed by hormonal replacement. She was started on oral steroids, following which her symptoms completely improved and she is doing well right now. Thank you. Now moving on, my colleague, Dr. Yatharth will be presenting the second case of the evening.
Good evening, everyone. Continuing with the first case, I present an interesting case of cavernous sinus syndrome. My patient, a 14-year-old girl, right-handed resident of Ambala, presented with complaints of double vision of 2 months duration.
Dr. Yatharth, you need to share your slides. These are visible now. Yes.
Yes, ma'am. Thank you, ma'am. Good evening, everyone. Now continuing with the second case, an interesting case of cavernous sinus syndrome. My patient, 14-year-old girl, right-handed, presented with complaints of double vision of 2 months duration, which was initially present on looking towards the right side. It was binocular with horizontal separation of images, and it progressed over a period of 1 month, such that she developed diplopia even in primary gaze. There is no history of headache or any focal neurological deficits, and there was no history of these symptoms in the form of fever, weight loss, or loss of appetite. Rest of the history was not significant. On examination, her vitals were stable. She had Marfanoid habitus with arachnodactyly, high arched palate, arm span more than height, thumb sign was positive, wrist sign was positive, and she had bilateral cervical lymphadenopathy with with a lymph node on the right side measuring 1 by 1.5 centimeters. However, her cardiovascular system examination was normal. CNS examination, her fundus was normal. The only abnormality noticed was on the eye movements, in which she had bilateral lateral rectus palsy, left more than right. As we can see in the images, in primary gaze, she has bilateral esotropia, right more than left. However, as we can see by the arrows pointed, she has lateral gaze palsy bilateral, with the restriction is more on the left side as compared to the right side. Rest of the CNS examination was within normal limit. So, summarizing my case, this 14-year-old girl with Marfanoid habitus presented with insidious onset, gradually progressive diplopia in the right lateral gaze, followed by diplopia in primary gaze, and examination revealed bilateral lateral gaze restriction with left more than right. Now, moving on to the course of the sixth nerve, as we can see, the sixth nerve exits from the pons anteriorly and then travels anterolaterally in the subarachnoid space. Then it pierces the dura and ascends along the clivus. And after reaching the petrous apex, it takes a sharp turn to enter the Dorellos canal, which is limited laterally by the petrous apex, medially by the posterior clinoid process, and superiorly by the petroclinoid ligament. After traveling through the Dorellos canal, it enters the cavernous sinus, where it is continuing in the lumen of the cavernous sinus, and then it enters the orbit via superior orbital fissure. Since our patient has involvement of bilateral abducens nerve and there is no headache and no systemic features, the dural involvement is less likely, and we localize our lesion at the clivus. This is a picture of cavernous sinus showing the bilateral cavernous sinus. What we want to emphasize is that if there is a lesion in the midline, in the sella, or involving the pituitary gland, if it grows in size, it will cause involvement of bilateral abducens nerve, and it may not involve the other cranial nerves, namely third, fourth, and fifth, which are present in the wall of the cavernous sinus. So presentation may be with only bilateral abducens nerve involvement in the initial stages. This is the analysis. And moving further, she reported to a private hospital with these complaints, where MRI brain was done, which was showing a space-occupying lesion involving the sella paracellular region. In view of this space-occupying lesion, she was referred to neurosurgery ESOPD. Due to our previous experience with our neurosurgeons, where many atypical masses have turned out to be, retrospectively have turned out to be inflammatory, a serum IgG4 levels were already sent. When her serum IgG4 levels turned out to be very high, more than 2,500, she was referred to neurology OPD for further management. Now, neuroimaging. These are the axial T1 images of the brain of our patient, which show an iso-intense lesion in the anterior to the brainstem, anterior to the clivus, and is extending to involve the sella. And it is these are the T2 images showing showing heterogeneous intensity lesion anterior to the clivus and involving the sella. And as we go on to the T2 flare images in the coronal section, we can appreciate the heterogeneous intensity lesion extending from up to the nasopharynx. This lesion is also pushing the optic chiasma upwards, as can be seen. This image with the arrows pointing show that the lesion is also pushing the right carotid artery and narrowing the lumen of the carotid artery, although the lumen is not completely compromised. These are the sagittal images of our patient. This is the T2 image of our patient, and we have put another image of a normal individual for comparison. As we can see in the normal image, we have soft tissue in front of the clivus, we have the soft palate and the maxillary sinus. However, in our patient, since there was a mass which was growing in front of the clivus, the maxillary sinus is obliterated, as can be shown by the arrows. These are the axial post-contrast images of our patient, which show heterogeneous contrast enhancement in the lesion, which can be appreciated in the center. And this lesion is extending up to the sella. So what are the possibilities? The first possibility we considered after in this patient was clival chordoma. However, the points against are that it is rare in individuals less than 40 years and is more common in males, and there was no headache. The second possibility we considered was of nasopharyngeal carcinoma. However, it is more common in elderly and presents with B symptoms which were absent in our case. The other possibilities we considered were inflammatory like sarcoidosis or IgG4 disease. However, since there was no dural involvement, no systemic involvement, so these possibilities considered were lower down. Further evaluation, as we have already mentioned, that serum IgG4 had come very high. And further evaluation showed that interferon gamma turned out to be positive, and MAN2 showed a induration of 20 millimeters with minor abnormalities of hormones, LH and growth hormone. The routine investigations were normal. The meanwhile, surgeons, before referring the case to us, had already sent multiple granulomas with surrounding lymphocytic collar and necrosis within the granulomas. As we can see, the magnified image, this shows giant cells, multinucleated giant cells, a lot of necrosis within the lesions. We also did a IgG4 immunoperoxidase stain, which shows scattered IgG4 cells throughout the tissue. However, as compared to the previous case where we have clusters, there are no clusters seen in this patient. And then a PET scan, whole body PET was done, which showed very interesting findings. In this case, at present, we can see that there is thickening of the dura on the right side, and there is tentorial involvement also bilaterally. However, FDG avidity can be seen on the right side. This is a coronal section of the NCCT brain, which shows that the mass is extending towards the right side. And the PET CT of the chest showed consolidation with cavitation in the right lower zone, which showed FDG avidity uptake. A thickening of the IC junction was also seen on the NCCT, and PET scan showed highly FDG avid uptake in the ileocecal junction also. A lytic lesion can be appreciated in the left iliac bone, which also showed FDG avidity, along with a lytic lesion in the lumbar vertebra and highly FDG avid uptake. A final diagnosis was made of granulomatous necrotic space occupying lesion involving the clivus with pulmonary, gastrointestinal and skeletal involvement, likely disseminated tuberculosis. This patient has been started on ATT with effect from 26 June, and at present she is doing well. The learning point from this case is that this is a very atypical presentation of tuberculosis in which there is no headache and no systemic features, and still the diagnosis turned out to be disseminated tuberculosis. Thank you very much. Now I hand over the presentation to Dr. Ria.
Good evening, everyone. I'm Dr. Ria. I'll be presenting the third case in the series of this cavernous sinus syndromes. And like the above two cases, though the localization remains cavernous sinus syndrome, this case also had an altogether different etiology. So this 45-year-old gentleman initially consulted the neurosurgery team with history of bilateral diminution of vision since the last 1.5 years. There was also some history of headache and diminution of double vision since the last 1 year, and then he was referred to neurology for further evaluation. When we took the history, there was since November 2022, he had left eye vision loss, which was painless and progressive over the next 1 year, and only perception to light was present in that eye. By April 2023, he also started complaining of difficulty in getting up from sitting position or climbing stairs, and there was a history of proximal weakness, which was also painless and progressive. It was, though the patient was ambulatory, there was wasting and fasciculations present. He did not complain of any sensory symptoms or any form of distal weakness. By May 2023, there was a history of double vision in the form of horizontal binocular diplopia, which lasted for 3 months only and resolved spontaneously without any treatment. There was, since May 2023, he also started complaining of headache, which was bifrontal, throbbing, and it was only mild, continuous, daily, and he did not require any form of analgesics for the same. By November 2023, he also developed diminution of vision in the right eye, and he was only able to see outlines and unable to identify faces when he came to us. Throughout this history of 1.5 years, he also had unintentional weight loss of around 10 kgs. But he did not complain of any history of low-grade fever throughout the illness. So when he came to us on examination, the general physical examination was quite striking. As you can see, there are this lumpy, bumpy appearance of the neck. There was presence of large nodular lymph nodes that you can see, and there was bilateral cervical lymphadenopathy. On palpation, it was non-tender and rubbery in consistency. It was not matted, and this was associated with cachexia. There were also these multiple well-defined keratotic papules, which were evident on the hand. So keeping in mind the lymphadenopathy, the background of weight loss, and this skin lesions, some suspicious skin lesions, when we came to the CNS examination in the cranial nerves, he had a visual acuity of finger counting at 2 meters in the right eye and only PL positivity in the left eye. There was also left RAPD, and as you can see in the fundus images, there was bilateral optic atrophy on examination. On motor sensory examination, as you can see in the images, there was wasting of the anteromedial compartment of the thighs, which was more evident on the right leg as compared to the left. On examination, there was hypotonia in the lower limbs, and power at bilateral hip was 4/5, and right knee extension and flexion both were 3/5. There were brisk TTR, but left ankle jerk was absent, and bilateral planters were flexor. There was also sensory loss in the right leg in the L4 dermatome on examination. So, concluding all the substrates, we have bilateral sequential vision loss. I would like to localize it to anterior visual pathway. Initially, it was the left eye, so the left optic nerve followed by the right optic nerve. Would like to keep it posteriorly where both can be involved, likely at the chiasma or the cellar region. In between, he also complained of double vision. So there must be some oculomotor nerves involvement, 3rd, 4th, and 6th, which is not clear in the history. He did not had any ophthalmoplegia on examination, probably involvement of left cavernous sinus as well. Headache was present since the last 1 year. It was non-localized, just diffuse, dull aching, continuous, no variations. Likely dural involvement around the cavernous and orbit. It was bifrontal also. And bilateral lower limb weakness was a new substrate in this series of cavernous sinus, as we can see with the 3 cases. So I'd like to localize it to radicular involvement in view of wasting and fasciculations. However, the absence of pain was quite odd in this case. Brisk reflexes throughout also signify some myelopathy component as well, which we would like to confirm further on imaging. So when we imagine it in a diagram, as we can see, it initially involved the left optic nerve, slowly creeped around the dura, which led on to the headache, might have also involved the left cavernous sinus, the nerves in the left, oculomotor nerves in the left cavernous sinus, which have led to some diplopia transiently in between. And then it might have also progressed to involve the right optic nerve around the cellar paracellar region around the chiasma. So this is what we would like to imagine it as we turn out to evaluate the patient. So the final substrates of the patient being bilateral optic nerves, meninges, multiple lumbosacral radicals, and spinal cord above C5 because all the reflexes were brisk, likely around the cellar paracellar region with involvement of left cavernous sinus and pachymeninges with myeloradiculopathy at probably multiple levels in the background of lymphadenopathy and weight loss in this patient without any fever. So when we come to the etiologies, in the background of no fever, such long history, no other substrate involvement. Infections, I would like to keep less likely. The first, yes, inflammatory, definitely. IgG4 related disease can present with lymphadenopathy, as well as the symptoms like we have cavernous sinus. Obviously, IgG4 becomes an important differential. On the same coin, sarcoidosis also becomes a differential in the background of lymphadenopathy and weight loss. But with unintentional weight loss, there was a midline involvement. Lymphoma, leukemia, carcinomatous deposits that remain a high possibility. Also, histiocytic disorders keeping the midline involvement, the cellular, paracellular lesion, the lymph nodes. Also, adding up a new substrate leads to something that is much, much more than IgG4 related disease, as we have seen in the previous cases. So I'd like to keep this differential with my mind and lead on to the evaluation of the patient. So this was the imaging of the MRI of the cervical region, which was done. And as we can see, these are the multiple lymph nodes that were evident also on the clinical examination. These are beautifully seen in the radiologically. Also in this imaging, we can see that there was also enhancement of the nerve roots at the cervical level, for which the patient did not complain. He did not have any hand weakness or any sensory complaints in the hand, but he did have wrist reflexes in the examination. This was the coronal T1 image, which was showing an enlarged lacrimal glands, more so on the left side than the right, but both the lacrimal glands were also involved. This is the T1 pre-contrast and post-contrast coronal imaging of the brain. And as we can see, these are these masses, contrast enhancing nodular masses in the cellular and paracellular region, which is also, this enhancement is also creeping along the dura in the basifrontal region. It is also there is also enhancement of both the cavernous sinus bilaterally, as well as it is also going through the Meckel's cave. So though the symptoms were less, but the imaging was showing diffuse involvement of the pachymeninges with nodular masses in the cellular and paracellular region, as is beautifully seen in this image. This is the same T1 axial image showing the same findings of cellular paracellular enhancement along with diffuse hypertrophic pachymeningitis, which is also seen in this case. Again, along the sagittal section, it is also showing a dural tail. And that is why radiologically and plaque meningioma also becomes a differential in this case, because they can exactly present like this on the, at least on radiologically, it can present like this. This was the spine imaging done for the patient. And as we can see, there is a intramedullary, extramedullary intradural lesion, because there is expansion of the CSS space at around C1, C2, and it is hypointense on T2. And similarly, it is homogeneously contrast enhancing and compressing the cord, which might have led to wrist reflexes. Similar contrast enhancement is also seen in the thoracic cord, along the thoracic cord. And the patient had this was the axial sections of the same level. And we can see this is the T1, T2 hypointense lesion along the nerve root. Similarly, contrast enhancing, as is seen in this image. In the lumbosacral region, again, as we can see, T2 hypointense lesions along the nerve, masses around the nerve roots, for which the patient also had weakness. And these are beautifully enhancing in the contrast images, as you can see. Because of the motion artifact, the images are not that clear in this section. But there are large masses, as we can see. Coming to the routine examination, the patient had anemia, which on workup turned out to be there was minor anisopoikilocytosis, and red percent was 0.8, suggestive of hyperproliferation. His ESR was raised 75 mm per hour, and CRP was also raised. Vasculative worker ACE levels were negative. However, the IgG4 levels were significantly elevated, as we can see, 7,563. And although the dural enhancement was also encasing the pituitary, he did not, his hormone profile was absolutely normal on evaluation. We went ahead with brain and lymph node biopsy for this patient. And this is the lymph node sections. We can see cyclin D1 positive cells, and these are also IgG4 staining cells. On the lymph node biopsy, there was around 60 to 80 IgG4 staining cells per high power field. With the brain biopsy, we saw the significant finding of emperipoiesis. Emperipoiesis is a cell within cell appearance. There is a large histiocytic cell, as we can see. This is a large histiocytic cell, which has intact lymphocytes within. They're not phagocytosed, they're intact lymphocytes within, which is also, this appearance of the cell is called emperipoiesis, and it is characteristic for the disease that we are going to see. The brain biopsy sections were also positive for cyclin D1. The cells were positive for cyclin D1, and IgG4 staining was also present in the brain biopsy with around 40 to 60 cells per high power field. This was the brain biopsies. So the patient was given steroid pulse followed by oral dexamethasone 20 milligram per day, slowly tapered to 8. Currently, he is on 8 milligram per day over the last 3 months, and sirolimus 2 milligram per day was also added. So at 3 months follow-up, when the patient came to us, his visual acuity, though it was only finger counting at 2 meters, in the right eye, there was mild improvement in the left eye. As there was perception to movements, and hand movements close to face was the visual acuity. Power has also improved to 4+ by 5 at hip, and the knee power, which was 3 by 5, was 5 by 5 now on follow-up. The follow-up imaging at 3 months, as we can see, there are cellular and paracellular masses, but the the pachymeningeal enhancement has significantly reduced along the sinuses. It will be much better seen in the coronal images comparing to the images that we have seen earlier. The enhancement and the size of the masses have reduced. The cervical spine and the thoracic spine enhancement remains the same. However, in the lumbar roots, as we can see, the size of the masses have reduced, especially at the lower levels. So there was definite improvement with the therapy, and the final diagnosis of the patient being cellular paracerebral involvement with myeloradiculopathy, granulomatous inflammatory hypertrophic pachymeningitis of the non-Langerhans cell histiocytosis, the final diagnosis being Rosai-Dorfman-Destombe's disease, which is IgG4 related. So this case in the series highlights that the need for clinical examination, because if the lymph nodes and the background history of weight loss was very important for this case, and also not to stop at a particular level. We would have stopped at IgG4 levels and labeled it as an IgG4 related disease, but we went ahead with the biopsy, and then we found out that it could be something else. And that is the importance of a full evaluation and a detailed clinical examination, especially in this case. Thank you very much.
Yes, thank you, Ria. Can you stop sharing your screen? Are my slides visible?
Yes, they're visible, Dr. Karthik.
Yes, yes, thank you. So a very good presentation by all 3 of you. So today we have seen a lot of cases of painful ophthalmoplegia. The etiology of painful ophthalmoplegia can vary widely from vascular causes to infectious to non-infectious and neoplasm. But what I'll be dealing with is particularly non-infectious inflammatory causes. And when you talk about non-infectious inflammatory causes affecting the cavernous sinus syndrome, the first thing that you know is Tolles-Ahern syndrome, which is an ophthalmoplegia secondary to a granulomatous inflammation of the cavernous sinus. This Tolles-Ahern syndrome is an epinym of 2 different researchers who independently described a series of such patients which they presented to them. It is basically an investigation negative inflammatory cavernous sinus syndrome. The clinical features being involvement of can be having unilateral, sequential, or simultaneous involvement, but most commonly it is unilateral. It's the most defining feature. It can have periorbital, retroorbital, or hemicranial headaches, and this usually precedes the ophthalmoplegia by at least 2 weeks. The most common cranial nerve involved is the 3rd cranial nerve, followed by 6th, 5th, and 4th, and 2nd also can be involved. And it shows a dramatic improvement with steroids. So basically, if you are looking at the diagnostic criteria, you must have a unilateral, it's ipsilateral to the granulomatous inflammation. It's either done by an MRI or a biopsy. And you should have one or the more cranial pathologies, ipsilateral 3rd, 4th, or 6th nerve involvement. And it should be after the exclusion of all other causes. How do you exclude all other causes? The diagnostic evaluation, first you have to say this is investigation negative. Make sure that your investigations are proper before you say these are investigation negative. What we order is a contrast MRI of the orbits and the cavernous sinus. When you order a MRI of the contrast MRI of the orbits, ask your radiologist to do a dedicated contrast MRI with fat suppression, with T1 and T2 contrast sections in the coronal and axial sections. Why do you need fat suppression? Just look at this T2 image of the orbit. You look at the amount of fat which is disturbing the view of your orbits, your extraocular muscles, your optic nerves. But when you suppress the fat, you can clearly make out all the individual anatomical structures individually. When you look at cavernous sinus, you must remember how would a normal cavernous sinus look. A normal cavernous sinus has this classical biconcave appearance, smooth ones. And when you don't communicate to your radiologist, these bulging contour of the lateral of the cavernous are usually missed. Most of these cases are reported normal. If you don't tell your radiologist that what you're looking for, the patient had a lateral third nerve involvement. This was reported as normal. But when you see the classical concave appearance of the cavernous sinus is lost and you can see a bulge, this is involvement of the cavernous sinus. When you look at the cavernous sinus in the MRI, also look at the adjoining structures. You also look at the nasal and the paranasal sinuses. When you have involvement of a paranasal sinus, always rule out a fungus. This patient presented to us with left sixth and seventh nerve involvement. As you can see, there's an extensive inflammation of the sinus eroding into the oral cavity. And when you do a CT, you can always appreciate the significant bony erosions in these patients. Bony erosions can be seen in cases of fungal and malignancy. You always think of this. Rarely you can see bony erosions in IgG4 related disease also. When you look at other other sites that you have to look for is the lacrimal gland enlargement. Normally, you don't get to see a lacrimal gland enlargement on your MRI. But when you are having diseases like sarcoidosis, cysticercosis, and IgG4 related disease, these organs can readily get enlarged. And very important, these are a very easily accessible biopsy site. Whether you want to get an angiography or not, it's just to rule out any vascular abnormalities if you're suspecting them in the cavernous sinus. Most commonly, you'll get to see a cavernous, the ICA part of the cavernous sinus being narrowed when you have severe stenosis. Sometimes when you get thrombosis, you always have to think about an angioinvasive disease like a fungus or a high-grade malignancy in this patient. So when these patients come to you, you have to get all the ancillary investigations just to look at the systemic involvement. You have to get the vasculitic markers, ESR, ANA, ANCA, VRL, MONT2. Tumor markers look for malignancies, ACE levels, and IgG4 levels. The most important thing that you look for is in the systemic involvement is a PET scan. With a PET scan, you can always look at the pattern of involvement. Like if you have IgG4 disease, you can look at the involvement of the pancreas, salivary glands, prostate, and the retroperitoneum. Sarcoidosis has involvement of the lung and the mediastem. Histiocytosis like erythema, Rosai-Dorfman has lytic lesions, significant lymphadenopathy. And if you are looking at metastasis, you can always identify primary. And PET always gives you an extra cranial sites for biopsy, and it can be used as a follow-up tool also. So all these diseases will require a biopsy. Cavernous sinus biopsy is a very technically demanding procedure, and it can have a lot of comorbidities. We always look for an extracranial sites like lymph node, salivary gland, lacrimal gland. If you're not, we look for other adjacent tissues like sinuses, pachymeningitis. This patient had actually presented to a left-sided palsy. You can see the cavernous sinus is enhancing, and the lesion is actually eroded into the sphenoid sinus. We got a very easy access through a transnasal endoscopic biopsy. Patient later IgG4 related disease. So when you get a patient of these when you get biopsies in these patients, you can see many different patterns. Most common being in fluorescein, you can only get to see a non-specific granulomatous inflammation with some fibroblasts and plasma cells. IgG4 related disease, you'll get a classical IgG4 staining cells. More than 40% of plasma cells will have this. You have a reform fibrosis that will basket wave appearance, and you have ability to periphlebitis. Sarcoidosis, as you all know, has non-caseating granulomas. A word about IgG4. It is basically a chronic multisystem inflammatory disorder. The only thing differentiating this from a Tolosa hunt is it has a multi-system involvement, and it has a progressive nature, and it requires a long-term immunomodulation. As we have all studied about the neurological manifestation, can range from hypertrophic tachymeningitis, tumor like masses, cavernous sinus involvement, hypophysitis, orbital inflammatory syndrome, dacryoadenitis. What you see in this imaging of IgG4 is most important is these have a continuous sheet enhancement with homogeneous enhancement. They on T2, they have T2 hypointensity because they have extensive fibrosis. Fibrosis will be seen as T2 hypointensity. And they have bony erosion sometimes. All these features may mimic a fungal infection. So they might be reported as a fungal infection, but you always have to rule out an IgG4 in this case also. So when you get an IgG4 related disease, you obviously send these patients for IgG4 levels. IgG4 levels is elevated in 70 to 80% of patients. We have seen the pool sensitivity between 86 to 88%. It has a specificity of 90%. So 10% you have still be missing. Elevated IgG4 levels have been reported in 5% of asymptomatic individuals. And this 10% false positives can be in any disease which you have systemic immune-mediated response, like respiratory biliary malignancies, infections. Bronchial asthma is very commonly associated with raised IgG4, myeloma, hyperglobulinemia, and other systemic inflammatory disorders. Normal levels do not actually exclude the disease in this patient. So there are a lot of diseases which actually mimic an IgG4 over time. There are a lot of diseases which have raised immunoglobulin levels, like Rosai-Dorfman disease can have an involvement of meningitis, can have hypophysitis, and sometimes biopsy is also doubtful for IgG4 related. But massive cervical lymphadenopathy is very unusual in IgG4 that might be able to differentiate. Erdheim is also one disease which mimics IgG4, but they have a lot of bony involvement and lytic lesions in the patient. Other diseases like sarcoidosis can have meningitis and have a kind of involvement in as IgG4. Rare diseases like vasculitis, plasma cell dyscrasia, hyperinflammation can also can confuse the picture. So how do you say this is IgG4? A lot of clinical criteria have been established, the most comprehensive one being clinical comprehensive clinical diagnostic criteria. You should have a clinical examination that shows diffuse or characteristic involvement, and you should have a hematological evidence of raised serum IgG4 levels, and a histopathological examination which shows a definite IgG4 presence of plasmacytic infiltration story from fibrosis and obliterative bacteria. Definite is when you have all three positive. Probable is if you have histopathology and a clinical examination. Possible is if you don't have an histopathological examination, only an imaging and your blood level. How do you manage these patients of inflammatory cavernous sinus? Tolosa-Hunt syndrome is usually self-limiting, and steroids are just given to hasten the recovery. When you have involvement of vision or optic nerves, you just give them content early. We usually give a pulse methylprednisolone followed by oral tapering steroids. The recovery is rapid. The first thing to disappear is your headache, and you can have complete recovery within 6 to 8 weeks. A subset of patients which will have a long recurrence episodes may require a long-term steroid therapy or steroid sparing agents. But the management of IgG4 related disease is different. Steroids are the mainstay. You have to continuously give them steroids. Most of these patients completely recover on steroids alone, and we usually stick to these steroids very slowly at around 5 milligrams per week, per every 2 weeks. And these patients will require a maintenance with steroid sparing agents like azathioprine, mycophenolate, methotrexate. Nowadays, we have seen a lot of data coming up with rituximab as a very good steroid sparing agent. And when you stop therapies, they are very much predisposed with having recurrences when you stop in these patients. So I like to conclude with that we still in this days and era, we still have to have a clinical examination. Each that we order must be interpreted in the setting of the clinical examination. The disease nomenclature does change over time, and we need to follow up all these patients when you have such a rare and unusual patients so that proper diagnosis can be done in the future also. Thank you.
Thank you, Dr. Karthik, for your presentation. I can start sharing the last presentation if you stop sharing. Yeah. So as Dr. Karthik has just given a very nice closure to the first two cases, this presentation will deal about the closure to the last case which we dealt with, which was the case of Rosai-Dorfman Distombles disease. So very quickly, Moving from here, we all now know that Rosai-Dorfman or Rosai-Dorfman-Stambis disease is actually nothing but histiocytosis of non-Langerhans cell type with lots and lots of activated histiocytes within the affected tissues. And what are the affected tissues? They are predominantly the lymph nodes, and then there are some extranodal presentations also, as we just saw. Very quickly, in the revised histiocytosis classification, it belongs to the R group and is of two types, familial and sporadic. It can involve lung, skin, bone, lymph node, heart, practically all the organs which are possible here. So though it was described way back in 1965, it was in 1969 that it derived its name from the two physicians who noted classical patients of massive cervical lymphadenopathy and sinus histiocytosis on histology. And till now, there are just nearly around 1,000 cases which have been reported. So though it's self-limited, it can cause good complications because of its mass effect or infiltration into various organs. And as you can notice over here, it has a wide clinical heterogeneity. Many organs can be involved, and nervous system is involved in nearly 8% cases. Interestingly, around 43% patients will have extranodal involvement and probably will present with one or the other complications. So what we have to pick up is the clinical clue. So all that enhances, we know, is now not inflammation. So how do we think it can be more than IgG4? It is by these clinical clues, as was highlighted by Dr. Karthik also. So massive or a prominent cervical lymphadenopathy, good skin infiltrative lesions, which can be seen as maculopapular lesions, hypopigmented spots, and also macroglossia might point out along with the B symptoms of weight loss, fatigue, night sweats, etc. In central nervous system, it will involve more of meninges, then cranial nerves, and then pituitary and spinal cord are also other areas of predilection. So as I was pointing out, neurological RDD only accounts for around 8% of all the cases of RDD, and most of them are intracranial. Only 1/4 is the spinal RDD. It usually presents as dural masses and pachymeningitis. Parenchymal lesions, whenever they are usually seen in the infratentorial region, predominantly in the pontine region. CSF will show you lymphocytic pleocytosis, elevated protein, low glucose, and interestingly, as shown by Dr. Ria, emperipolysis. I'll just be covering a brief about this further on. So in the spinal cord, you'll see more involvement of cervical and dorsal spine, and a good 11% of patients will present to you with neuroophthalmic findings. And how these neuroophthalmic findings present to us is, again, either inflammation or infiltration or compression. So usually it's inflammation, and usually they present in head and neck area, and usually they present in the orbital area, like orbital inflammatory syndrome, in which they involve optic perineuritis. They cause optic perineuritis, involve the fat, involves the muscles, and also involves the other structures like eyelids, lacrimal glands, conjunctiva, corneal involvement, and may cause uveitis. And while causing this, they may cause compression of the optic nerve, hence causing visual loss, hence compressive optic neuropathy. Differential diagnosis has already been discussed. Just prominently, when inflammation is more, they present more, like granulomatous inflammatory diseases, IgG4 related diseases, sarcoidosis. And when mass effect is more, especially in the midline, they present like malignancies, like pituitary microadenomas or meningiomas, specifically when dural involvement accompanies the mass-like picture. So associations, again, IgG4 has been again and again highlighted that we have a syndromic RDD, which is associated with IgG4 related disorders, and they can exist very well together. Also, there is a close association of RDD with other autoimmune illnesses like SLE, autoimmune hemolytic anemia, and HIV. Also remember that a few cases may be familial, and these are the cases which will require a different treatment altogether, targeted treatment altogether. So this was just a collection of few patients who had presented in literature with IgG4 related Rosai-Dorfman disease, and it was noted that most of these patients had features with predilection to both the organs of both the diseases, meaning to say that IgG4 related disorders, as they involve lacrimal glands, salivary glands. So even in RDD, if these organs are involved, one should think of a combined presentation of RDD with IgG4 related disorders. The MRI pictures are just like IgG4, at least in the nature of presentation, which means now Rosai-Dorfman also presents with hypointense T2 lesions, ISO2 hypointense T1 lesions. You can notice this is again from the same patient Dr. Ria had presented, and they show a very good homogeneous contrast enhancement on gadolinium insertion. Just that these diseases are more nodular and they present more with nodular enhancement and nodular mass-like effects. They may mimic meningioma, as was again pointed out by Dr. Ria, and they may also have dural tail. So how do we differentiate? Most of the times it's based upon the involvement of the other organs, like looking at head and neck, seeing the lymphadenopathy, seeing the involvement of skin, pinna, seeing the bone erosion, seeing the prominent involvement of the orbit, and seeing more involvement of the central figures like cellular, paracellular regions. So other things have been covered up. So we see large histiocytes and watery clear cytoplasm, and we see empyropolysis, which means that you'll see cell within cell, a histiocyte engulfed by another histiocyte, maybe macrophage, and both these cells will be having morphologically unaltered signals, which means none is phagocyting the other. They are both there, just causing more burden of histiocytes, causing lots and lots of histiocytosis. So the consensus recommendations say that along with the routine investigations, we should also go ahead with serum immunoglobulins, autoimmune panel, look at what is the bone marrow status, whether any cytopenias are present or not, and see PET-CT to rule out other organ involvement. As far as management is concerned, in asymptomatic patient, a watchful observation can be done. But if the patients are symptomatic, specifically with mass-like lesions, resection of the site should be taking place and a biopsy should be taken. And most of these patients will require a good systemic therapy, specifically the ones who present with more than lymph node involvement. In severe cases, a targeted mutation-derived treatment should be given to these patients. And this is just a summary protocol of RDD. So corticosteroid, surgical resection, as I've mentioned, and the specific agents vary from the other inflammatory disorders. And that's the importance of knowing about RDD in specific. So we give sirolimus, we give chemotherapy, and we give immunomodulatory treatment like rituximab, imatinib, thalidomide, specifically in patients who are having extranodal involvement and are refractory or are having relapse. So with this, I again come to the key points of this presentation. So while we are understanding that IgG4 can be related, can be just an isolated syndrome and a very important part of granulomatous inflammatory disorder, it can very well present with other diseases like malignancies, like Rosai-Dorfman disease. Rosai-Dorfman, you think more when there is a massive lymphadenopathy, head and neck involvement, and systemic signs. The MRI picture is almost same to IgG4 related disorders, and these disorders are steroid sensitive, hence increasing the importance of knowing more how to pick up these diseases. And with this, I end this presentation, and thank you, everyone.
So thank you, everyone. Thank you, Astha, Karthik, Siddharth, Ria, and Yatharth. I think the important point that we have tried to highlight is how to approach cavernous sinus lesions and how to distinguish bona fide infections lodged in the cavernous sinus like fungus from a non-infective inflammatory disorder. The approach to the cavernous sinus is something that is not easy. But if a patient has multiple oculomotor nerve palsies, you think immediately in terms of a cavernous sinus lesion, right? And then you tell your neuroradiologist to scan the cavernous sinus, scan the sella, and scan the superior orbital fissure. Please don't fill in a form saying scan the brain. That will automatically take half the value of an MRI away. You have to specifically direct the neuroradiologist towards the lesion in the cavernous sinus. The important points that have been made is there is this very prominent group of disorders called IgG4 related disorders. Why are they called IgG4 related disorders? Because plasma cells here secrete IgG4. There are different types of IgG which are secreted by plasma cells. This is a specific type of IgG called IgG4, which is secreted by the plasma cells and produces non-specific inflammation in the cavernous sinus and in the adjacent structures like the pituitary. Rosai-Dorfman is a separate entity altogether, characterized by thick blobs in the brain and rarely in the spinal cord. And it is a chronic histiocytic disorder, which is different from IgG4 group of diseases, which are characterized by non-specific inflammation. Steroids and immunosuppression are the mainstay. I once again emphasize that before you make a diagnosis of IgG4 related disorders, please ensure that you have ruled out a more malignant disorder like mucor in diabetes, mucor in the immunocompressed. Now, doing that is not easy, but it's not difficult either. If a patient has got long-standing fever, if a patient has got loss of weight, loss of appetite, in that case, you think in terms of a fungus rather than IgG4 and related disorders. Please remember, if you miss IgG4, patients are likely to recover spontaneously. But if you miss a fungus, you know the consequences. They'll be diabolical both for the patient and for you in terms of your reputation. So the long-term prognosis for IgG4 disorders has changed with the advent of immunosuppression. Steroids are the mainstay, as was pointed out by Dr. Asta and Karthik, and of course the senior residents. The duration of steroids is variable, depending upon the aggressive tempo of the disease. If it is just isolated to the cavernous sinus, in that case, probably 4 weeks would be enough. But if it has gone beyond the cavernous sinus, causing a hypertrophic pachymeningitis, you need to prolong the duration of steroid therapy. CSF is helpful, but not confirmatory. One final important message: serum IgG4 can be normal in bona fide IgG4 disorder. Serum IgG4 can be elevated in a disease which is not IgG4 related. So we have shown you cases where the serum IgG4 was normal, but when we did a biopsy, it turned out to be bona fide IgG4. And then there's another case which we showed you where the IgG4 had gone through the roof, but that turned out to be a non-IgG4 neuroinflammatory disorder. So with that, I come to the end of this session. I'm thankful to all of you for having listened to us and hope to see you all again. Back to the chairpersons, Professor Sudhir Shah and Professor Professor Narsimran. I'm so grateful that you've given us a chance to be associated with this wonderful, iconic lecture series. Thanks, Manojji. Thanks, Astha. Thanks, Arun. And thank you so much, Shweta. You've been doing a fantastic job and keep up the good work. Namaskar, Jai Hind.
Dr. Lakshmi would agree, and all delegates would agree that this was one of the most interesting case series. All 3 cases were wonderful. The case presentation, the dissection of the cases, and localization, and the key points of learning were all really great. I think this was one of the few top case series of our whole webinar series, and thanks to Professor Lal and the team for having presented all these most beautiful cases. And I think, as you rightly mentioned, you have a plethora of such cases in neuro-ophthalmology, and that makes you distinctly quite superior to many other places and institutes. Dr. Lakshmi, kindly give your remarks, and then we might have some questions also.
Sir, a wonderful collection. I think the boys are blessed to have such a beautiful collection of cases. And as you should know, sir, we have, I think this collection of cases are of international standards, and the discussions were so good, sir. And my congratulations to the entire team. And there are any, just 1 second, sir, I'll just see the few. There is one question from Ram Kumar. For third nerve palsy, which MRI sequence to be done?
So it's a simple, straightforward, plain plus contrast MRI of the third nerve, starting from the brainstem right up to the cavernous sinus. There is no specific sequence for the third nerve. There are cis sequences for cranial nerves, but the third nerve can be easily a thickened, involved third nerve can be picked up by a non-cis sequence. Ideally, cis sequences are required to pick up fifth and sixth nerve, but for the third nerve, you can pick that up in a simple 1.5 Tesla machine, contrast MRI from the brainstem to the cavernous sinus.
So there's one, in the chat box, there's one question. In the first case, was there storiform fibrosis?
Okay.
Yes, sir, there was storiform fibrosis in the first case. I think it has also been shown by Dr. Siddharth, the storiform fibrosis in one of the images which was there. It was fulfilling all the criteria of IgG4 related disorder, and hence she was given the diagnosis of IgG4 related lymphocytic hypophysitis and granulomatoous inflammation of the cavernous sinus.
And second case, some comments, MRI not showing the T2 hypointense lesions which are characteristic of IgG4.
Yes,
One
sir.
comment.
Yes, sir. And hence it was not IgG4 related disorder. It was not showing the characteristic feature in the MRI. And that is why we see that in the end, it was a googly, I would say it was a mimic. It was tuberculosis, which was mimic.
Yeah,
We never made the diagnosis of IgG4, sir.
The greatest masquerader, how it would.
Yes, sir.
And apart from that, and I just, the other things are only the accolades given to the entire team for a great presentation. That was what most of the other chats are there. My quick questions to you. What decides the emperipolis in Rosetta? Why do the cells don't, moment it gets, normally what is the, all of us know that the cells whatever gets inside gets digested. The lysosomal, what is this? What is it that prevents the degradation? Why the intact cell lives inside the?
Probably with the oncogenic mutations. It is known that all these patients, this RDD is actually derived from the oncogenic mutations, and varied oncogenic mutations have been described, including NRAS, KRAS, like we see. So it's probably that oncogenic mutation which lets it survive, and hence probably the histiocytes, they keep on accumulating, causing histiocytosis. So that is, yes, sir.
The hemophagocytic as well as the both kind of emperipolises are described in Rosetta, or only
no, sir. Sir, in Rosai-Dorfman, only emperipolisis is described. In so this hemophagocytic syndrome, etc., they come into separate headings now. So they are no longer under the headings of RDD. Under the histiocytic classification, the revised histiocytic classification, which I was showing. So these acute illnesses which are derived from infections, vaccinations, or sepsis, they come under a separate heading now.
Okay, thank you. Wonderful presentation, Kapila. I really enjoyed it, and my sincere thanks to the entire team. Over to Sir Professor Sudhisha, sir. Any comments from your side, sir? It was a real treat, sir.
Yeah. Thank you, Dr. Lakshmi, for your comments. Professor Lal,
sir,
I had one question, that there are some specificity and sensitivity issues with IgG4 levels, and that the laboratory may not be very accurate in the, judging the IgG4 levels. Now, which exact conditions make you think of taking biopsy in IgG4 suspected cases?
I think
because all the time it may not be possible, and sometimes you have to rely. So, in your personal opinion, could you please highlight exact indication of biopsy in IgG4 cases, suspected cases?
Beautiful question, lovely question, very practical question, and my answer is very straightforward. The first rule of medicine is, if you cannot do any good, do no harm. So when you are doing a biopsy, you have to ensure that you don't harm the patient. And the only way to ensure that is take biopsy from a safe area. And the only time we feel comfortable taking a biopsy is when the lesion is either in the superior orbital fissure orbit or in the sinuses. We never touch a lesion which is in the cavernous sinus alone. Remember, cavernous sinus is a very strategic sinus. It is a very sacred place. No surgeon can touch the cavernous sinus without causing complications. Even the best in the world will have sweating if they reach the cavernous sinus. So the best thing to do is pick up a biopsy from an endoscopic route through the sphenoid sinus. Enter the sphenoid sinus, that's a safe zone, and take a biopsy from there. Or you can take a biopsy from the adjacent orbit, but never take a biopsy from the cavernous sinus. That's for sure. And in the last 20, 30 years, I can safely tell you, I have taken a biopsy from the cavernous sinus only once. Professor Khosla, I wanted a diagnosis. At that time, I was very young, crisp, and I didn't know about these group of disorders. And when of course, the patient survived. But when the patient came out after getting a biopsy, it was like he had been shot through the head. His eyes were bloodshot and all, and I swore on God that I am not going to touch the cavernous sinus again, and I have stuck to my principles. It's only when the lesion is in the sphenoid sinus, when it can be accessed from the nose, when it can be accessed from the maxillary sinus or from the periphery, do we venture to do a biopsy. Another very important aspect which has not been covered here because of paucity of time is we do PET in every patient of IgG4 disorders. And PET invariably will show us some peripheral region, say the lacrimal gland, say the parotid or the submandibular gland, which can be accessed by biopsy. So that's as far as biopsies go. IgG4 with or without biopsy, with a clinical setting, remember you can safely make a diagnosis of IgG4 disorders.
So, one more question. I have two cases at least right now I'm handling in last 6 months who have IgG4 positive, CSF is reactive, but incidentally when I did CSF biofire also, that shows herpes Wizard V positivity. So the PCR positive for Wizard V. We treated with course acyclovir for 21 days. We demonstrated that CSF Wizard V is now negative, but IgG4 is still persisting positive. So my question is there any correlation or relation between Wizard V and IgG4 in your experience, or does that virus somehow activate IgG4 reaction?
The answer is yes, there may be, yes and no. Yes, the virus might tweak the immune system and give rise to IgG4 disorders, and no, because not all patients have a viral etiology for IgG4. But your question is, can it happen? The answer is yes. Does it happen? The answer is very, very rarely. I hope I've answered it very clearly.
Yes, absolutely. The reason why I'm asking you, sir, as soon as we stop steroid, the patient becomes symptomatic. What symptoms she has? She has one of the patient I'm talking about. She has fifth nerve sensory symptoms on V1, V2, and nowadays she has developed sensory symptoms on the same side of the tongue. So loss of taste. So it is a fifth nerve involvement very clearly seen on contrast MRI, and I don't know how to touch that, and I don't know how to diagnose that exactly, whether it is Wizard V related, IgG4, or how to go about that. So if you can please guide us.
You have already treated for VZV, infection. You have given 21 days Valsivir or XYZ. Now you cannot do anything beyond that. You have to treat the IgG4 disorder for whatever it is, right? You have to give steroids, and you need to give steroids for a long time. That's the bottom line. Repeat the MRI. If you have done it once, repeat it after 6 months.
Okay, sir. We'll do the follow-up and let you know what's happening, because we did second MRI. It shows the same lesion, and the symptoms are now increased, that now she has developed...
Sir, then there is an issue. It should not show the same lesion of the same size. Please remember, all patients resolve on follow-up MRIs. That's a fundamental rule of the thumb. If this one has not, then we need to have a hard look at the case again.
So, fifth now biopsy is the
No,
only
you
thing.
don't do a biopsy. No, not at all. Not at all. I'm not
Difficult,
asking
huh?
you. I'm just saying that we need to look at the patient, get a PET scan done, and then
PET scan is done.
what
PET
is the
scan
PET
does
scan?
not show any lesion anywhere else except this enhanced lesion on the fifth nerve. So we checked everything. Clinically also, she has only focal symptoms. IgG4 is positive, and the CSF is now not showing PCR positivity for VZV.
So
But cells, CSF cells are still persistent,
the
though they are
cavernous sinus is normal. The cavernous sinus is normal.
normal, sir, absolutely
So
normal.
then this is not IgG4 disease. Then this is clearly herpes simplex virus, HSV infection, which has led to sequelae. That is how I'll put it.
Yes, may I have some opinions, sir?
Yeah.
Yes, sir. So, as you're saying, sir, there's involvement of the left-sided trigeminal nerve, and it is not responding so well with your conventional therapy, and the patient is still having recurrences. Yes, first possibility, as you're saying, it could be a sequelae to a chronic viral infection. IgG4, we must remember that when you do a test, you have to have a clear idea what you're going to have. If it's positive or negative, you have to have a decision beforehand. If you have to interpret the test with what you're thinking clinically or not. If you're suspecting IgG4, we should have some mass lesion or some thickening along the nerve, like a dural thickening involvement of that fifth nerve. Rarely, what I have seen, I have two patients with fifth nerve involvement. One of these, which I have on follow-up, one of these patients turned out to be a lymphoma. Another patient incidentally turned out to be a Rosai-Dorfman disease involving the bilateral fifth nerves. So if this patient is having response with steroids, it can still be an immune mediated. But however, in the background, we cannot rule out a evolving malignancy in these patients. I think we can just follow this patient up and you'll see how the disease.
That's the concern. Karthik, that is a real concern. We are stuck. We want to exclude lymphoma and other disorders. And in CSF, we are not getting any atypical cell. Even the cytospin and flow cytometry is normal. And now BioFire is negative. So we are stuck. Ideally, we should be looking for lymphoma and other diseases. Sir also said that this does not look clearly IgG4. It could be something else. But radiologically, MRI-wise, PET-wise, CSF-wise, we are no wiser by repeating. So that's where I thought I could take your opinion.
Persistent thickening of a nerve is not a feature of IgG4 disorders. Resolution has to be seen. So until we don't see the patient, I don't think we can give you an opinion beyond what we have said, except that from our experience, resolution is the norm in IgG4 disorders on follow-up. If the persistent thickening is remaining, then it is in all probability a chronic viral herpes varicella zoster infection, which has tweaked the immune system and has left behind sequelae.
Okay. All right. So I'll keep you informed and we'll talk later on next MRI, what's happening. Okay. Thank you, sir. Thank you very much. Wonderful presentation, wonderful cases, terrific discussion, and it's a very enlightening session. Thank you once again to the team led by Professor Dr. Vivek Lal. And we all have really enjoyed the whole session. Thank you once again. Your previous case was also a wonderful case, if you remember, and this is also a wonderful case. Kapila, remember that case?
Yes, that went to, I think it was published in Neuro-Ophthalmology. It was a case of
Whipple's disease, yes.
Neuro-Whipple's disease. So that
Yes.
I was another brilliant case, oculomasticatory myoclonic. Myarrhythmia. Oh, that was fantastic. And that was also picked up on PET scan. And of course, I think a biopsy was done subsequently, Asta, hai na?
Yes, sir.
Yes, so we published it in Neuro-Ophthalmology.
Thank you. Wonderful, sir. Thank you very much. Okay, so over to Mr. Chadda.
Thank you very much, sir. And today we are incredibly grateful to all of you for joining us in celebrating the 4th year of Secret of Neurology. We have successfully completed the 48th session of this insightful web series. On behalf of Intas Pharmaceutical, I, Arun Chadda, Vice President of Intas Pharmaceutical, extend heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey over the past 47 months. A special thanks to you goes to our esteemed course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology. This program will undoubtedly be a valuable resource for all the DM and DNB students. And we are incredibly grateful to the young neurologists, Dr. Siddharth, Dr. Yatharth, and Dr. Riya Sharma for sharing their insightful case presentation, and our appreciation and also extended to Dr. Asta and Dr. Karthik for their meticulously evaluation of the case localization and discussion. And our deepest gratitude goes to Professor Viveklal sir, Director of PGI MA at Chandigarh. Despite of his busy schedule, he has taken out time to this gracious to grace this today's session, and he graciously shared his valuable experience with all these three cases, providing the crucial learning points and summarizing the proceeding of these unique presentation. Once again, a heartfelt thank you to all of you for your gracious presence. It's being a true player being with you today at the 48th session of Secret of Neurology. Once again, heartfelt thank you to all of you for your gracious presence. And it has been a true player being with you today at the 48th session of Secret of Neurology. We eagerly awaiting your return for the next highly anticipated session of Secret of Neurology on July 26th. Until then, stay safe and take care. Thank you. Thank you to all of you. Thank you, sir. Thank you very much.
Thank you so much, sir.
Bye, sir. Good night, everyone. Thank you.
Good night, sir.
Thank you. Thank you very
Bye,
much, sir.
bye, bye. Namaskar.
Thank you. Thank you. Thank you.
Mr. Chandra, stay back so that we can
Yes,
talk.
sir.